Hi, I'm Dr. Matt Russell from Teleon Laser Eye Surgery Centre, Brisbane, Australia. Today I'm going to share my favourite lens surgery technique, which is to use the CAPSULASER laser-assisted capsulotomy technique to implant a Femtis MF15 toric IOL. I perform the cataract surgery using the Zeiss Callisto system. I correct the main incision and the paracentesis before performing any other part of the procedure. Then I coat the cornea in the capsule gel before inserting the high concentration trypan blue. Now, creating the main incision at the beginning of the case allows me to efficiently remove the trypan blue after 60 seconds of staining the capsule. Now, it's very important to be mindful of the anesthesia and sedation. I prefer to have the patient lightly sedated at the beginning of the procedure and perform the procedure under topical anesthesia. Avoiding deep sedation until after the capsulotomy has been created is important because you may get heavy respiratory motion or maybe a head movement that might decenter the capsulotomy. What you can see is fairly dense staining of the capsule, but you will notice that there is a hyperintense circular area centrally that's an important landmark. The center of this area can be used as a guide to the line of sight. Achieving excellent centration is perhaps the most challenging portion of the CAPSULASER technique, but I also align this with the central area of hyperintense staining. Now, you can also use the patient target light in the laser, or you can use the Purkinje images to assist alignment. In most cases, the capsulotomy separates cleanly. There are some cases where there are tags attached to the capsulotomy and surrounding capsule, which can be managed with the capsulorhexis forceps or an Okahoshi cannula, such as in this case. The capsulotomy is robust, but it's really important to remember to gently hydrodissect to avoid prolapsing the nucleus into the anterior chamber and avoid the possibility of any anterior capsule tears. You can see in this case it's quite easy to remove a whole hemming nucleus through the capsulotomy without any significant stress or risk to the capsule. And being a very experienced cataract surgeon, I really do like the staining of the capsulotomy. I just think this adds another element of safety to the whole procedure. In my experience, anterior capsule tears are very rare. The capsule strength is more robust than the capsules in flak surgery in my experience. You can see it's quite possible to do bimanual IA without shifting hand position. The Femtis IOL is injected with a one-handed technique directly into the capsular bag without any additional viscoelastic. The irrigation cannula is being used as an AC maintainer. There are no endothelial concerns here because the IOL never is near the posterior cornea. At this point, I'm positioning the implant optic into the capsulotomy, a technique called enclavation. I maintain the AC using the infusion cannula and use a short sensitive hook. The technique is to position the most proximal anterior flange first. If the IOL is toric, I rotate the intraocular lens to the appropriate axis, then position the second anterior flange. The secondary flanges are adjusted, and following this, the toric axis is aligned perfectly using the Callisto guidance system. Really, at this point, you can begin to see some of the huge advantages of the Femtis platform in combination with the laser capsulotomy, and that we can perfectly orientate the toric alignment of the implant. Stability of the toric alignment over the long term is excellent. The ability to center the implant on the visual axis may also improve the quality of vision. Having the implant closer to the iris reduces negative dysphotopsia, and we've found that the EDOF effect of the Femtis platform is better overall than that of the Lentis platform. All of this results in what our ultimate goal is to achieve a high level of patient satisfaction. So our patient reported levels of satisfaction are 96%, either satisfied or highly satisfied with this surgical technique and implant platform. We market this as a premium cataract surgery, but we term it laser cataract surgery, which I think really captures the patient's imagination. We're also able to charge additional fees above the standard cataract surgery fee for this surgery. There are many nuances to this technique that can't be covered in a short video. I'd just like to say that I'm extremely grateful to Bevell and David Borden for developing the technology, and I'm also grateful for my colleagues who have shared their techniques to enable me to evolve my own. I hope this video can serve as a launching platform for your expanded approach to presbyopic correcting lens surgery, particularly in patients who want a high level of spectacle independence but are hesitant about lens replacement or premium cataract surgery because of night vision quality issues.